Great. So today's session, titled Missing Mothers, Solving Health-Related Social Needs to Reduce Pregnancy Complications and Maternal Mortality, is brought to you by GroundGame.Health. GroundGame.Health is a partner and great supporter of both MHPA and our health plan members. We greatly appreciate them organizing and pulling together today's session. With that, I will toss things over to Abner Mason and Meredith Welsh for introductions and today's presentation.
Thanks, Eric. My name is Abner Mason, and I am Chief Strategy and Transformation Officer at GroundGame.Health. And I'm joined by my colleague, who I'll ask to introduce herself.
Hi, everyone. My name's Meredith Welsh, and I'm Head of Service Delivery at GroundGame.Health and SVP of Operations.
Great. So before we dive in, I want to provide a little bit of an overview of who GroundGame.Health is. But even before I do that, I want to thank Meredith, my colleague. As some of the listeners will probably hear, she has a really bad cold. And instead of saying, I can't do it because I'm not feeling 100%, she's a trooper and she is here anyway. So Meredith, you have grace from us. We know that you've got a cold. We just appreciate you hanging tough and joining anyway.
Thank you, Abner.
So GroundGame.Health, one of the best ways to understand who GroundGame.Health is to appreciate the problem or the challenge that we are addressing, the problem we're trying to solve. And that is we are trying to be the connection, the pipes between health plans and other health stakeholders on the one hand, and community-based organizations on the other hand. So we're trying to connect two different types of organizations that, as we'll talk about in this in this session, two different types of organizations that struggle to connect with each other, but who we believe, and I hope you share this view, need to work together. Health plans and other healthcare stakeholders need community-based groups for a key reason, and that is that increasingly health plans and others are being asked to, and in some cases required to, address their members' social needs. And as we think about how you can address a member's social needs, we want to make the case in this session that a key partner for health plans as they develop strategies and implement strategies to address, and when I say address, to me, that's interchangeable with solve. So helping health plans to solve their members' social needs. As health plans get on that journey in a really sort of serious and rigorous way, we think that one of the best ways to make that happen in a sustainable way is to partner with community-based groups. And so GroundGame.Health, we sit in the middle between health plans and other healthcare stakeholders and community-based groups. We built a technology platform that allows us to, and I'll give you an example. If a health plan has a member who has a social need, they can refer them to us. We can put them on our HIPAA compliant and high trust platform. We can route them to a community-based group in their local community that is best positioned, and we'll talk about what that means, to solve their social need. That community-based group, we contract with them, just like we contract with the health plan. So we're in the middle, contracting with both, and we can work with that community-based group to make sure that members' social need is met. The community-based group can verify that the member's social need has been met through our platform. We then give that verification, that closed loop verification that the need has been solved. We share that back with the health plan, which allows the health plan to provide payment to the community-based group. So it's a sustainable solution. We're providing the solution across the country. And what we're finding is that it is really effective at solving social needs. And solving this problem that we have in our country, where you have these two different organizations who need each other, but really struggle to contract with each other. And the reason the need is great and is getting, I think, greater, and going forward, health plans and other healthcare stakeholders are going to need to do even more to address their members' social needs, is because regulators at the federal and the state level, accreditation bodies like NCQA and others, and the healthcare stakeholders themselves, we all recognize that health-related social needs or social determinants of health, interchangeable. They're the same thing, SDOH and HRSNs, but we're going to use the HRSN, health-related social needs here. They get in the way of the clinical need, the ability of health plans and others to address the clinical side because the social gets in the way. And based on a lot of data, we know a couple of things. One is that health outcomes are much more determined by those non-clinical interactions, so the health-related social needs, than they are by what actually happens in a visit with a doctor. So something like 80% of health outcomes are related to non-clinical issues in a given person's life, and almost half of consumers have at least one unmet health-related social need. And the majority who have one have more than one. And for folks in this session who are in the Medicaid program, I think I want to make clear that having a social need clearly is an issue for the Medicaid line of business. But we should all be aware that it's not just Medicaid. It's also Medicare. It's commercial. It's exchange. This is something that is common across lines of business, but there's no question in the Medicaid space, it's particularly important because of the nature of the program, and people who are low income really struggle with unmet social needs. And so let's talk a minute about some of the challenges that we face as we try to bridge that gap between health plans and the community-based groups that are in the best position to solve social needs. One of the big challenges we have is that the way our society has developed, the way the US has developed, we separate clinical care from social services. And that's just the way the country has developed. I think we're at a point now, it's an interesting point where we're starting to try to bridge that gap between the silos, between clinical and social. But we've got a long way to go because they're still very different. And even beyond just having organizations separated and funding streams separated, there's also an issue around willingness to get involved that we've got to, I think, take head on. When it comes to healthcare, and I'll use diabetes as an example, if you've got a diabetic, we are, as a society, willing to spend a lot of money on addressing that diabetic's clinical needs. Everything from remote monitoring to now a whole new class of drugs to address diabetes. We're willing to spend quite a bit to address the disease, but for that person who has diabetes, we are less willing to help them with food if they have food insecurity, even though we know that food insecurity, that either the lack of food or the lack of healthy food is going to mitigate and in some cases undo all of the work we've done on the clinical side. We're willing to spend on the clinical side, but we're like, I don't want to, we're reluctant to provide funding to help that person with food insecurity. We've got to address that as a country. We've got to sort of accept that clinical and social go together. People aren't half clinical and half social. It's the same person, and we're not going to achieve our clinical outcomes if we don't address the social. And we've got to make sure that our whole strategy is more whole person oriented, and that funding flows in a way that acknowledges that. I think that it's really important too that we acknowledge that as healthcare stakeholders, particularly health plans, who are going to be under increasing pressure to address or solve their member social needs, it's important that plans and health systems and providers, because they're having the same pressures, that they not feel that they have to medicalize social care, that they have to stop being great clinical organizations or organizations largely responsible for the clinical side and become social care organizations. We don't think that's the best solution. We think it makes much more sense for health plans and others to partner with social care organizations across this country. In every community, there are community-based groups that have as their mission to solve social needs of people who live in their community. These community-based organizations, they're geographically in the best place to help a given member because they're local. They have the trust and they have deep knowledge of the communities that they serve. They're in a much better position to to solve that social need than a clinical organization is. But one of the biggest problems is that these community-based groups really struggle to contract with and partner with health plans, as an example. In fact, we talk to a lot of community-based groups at GroundGame.Health, and what they tell us is these are examples of where they struggle. They say, you know, and I'll use food as an example again. The local food pantry that is in the best position to help a member who has got food insecurity, who has no food that night for themselves or their family members. That local food pantry is in the best position to help that family, to put food on the table that night so that those folks can eat. But that local food pantry, it might be connected to a church, it might be just a community organization, and they're not high trust. They're not HIPAA compliant. They don't have the insurances that are typically needed to contract with a health plan. They wouldn't even begin to know how to submit a claim to a health plan. Even if when they feed that health plan's member, they have no capacity to submit a claim. The health plan is willing to pay. The health plan says, I've got a member, they need food. If you give them food, I'll pay you. But that local food pantry is not in a position to submit a claim, let alone revenue cycle management, waiting long periods to get paid. So these are some of the challenges that community-based groups have. They're best positioned to solve these needs. They are, from a trust perspective, from a geography perspective, they can do it at a cost that is significantly less than a clinical operation can provide that same meal. But we've got to solve that problem that the community-based groups just aren't in a position to contract with health plans. And that's what we're doing at GroundGame.Health. We built a technology platform that allows us to contract with both. But I want to sort of double click now, because I just talked about from the CBO perspective, the challenges they face. I want to now get a sense from some folks in the session here for health plans. What are some of the challenges you face as you are implementing a strategy to address, and by address, I mean solve the social needs that your members have? So we have a poll question, and this is, you know, sort of looking at it from the other side. I just described the CBO angle. Now we're looking at it from the health plan angle. We're asking the folks in the session here to help us out and answer this question. So the question is, what is the biggest challenge your organization faces in solving health-related social needs? What is the biggest challenge your organization faces in solving health-related social needs? And we've got a couple options here that you can pick, a number of options you can pick from. I'll read them off. One is identifying members with social needs. So is that the challenge? Or is it limited or no access to local resources? Is it communication challenges, communicating with that member or the community-based organization? Is it engaging hard to reach individuals? These folks are hard to reach. They're struggling and they are difficult to reach. Is it confirming or documenting social need closure? Is it, if you want to do this and you're actually prepared to provide funding but you need to know that the need was solved, do you have problems or challenges confirming that the need was actually solved? And the last one here is measuring impact. Are you struggling with measuring impact? So I'm going to stop for a moment and just give folks the chance to answer the poll question. Cool. Well, thank you all for responding. That's really helpful. So let's see what Meredith, you and I can sort of look at what the responses are. So interesting, the number one in terms of difficulty is engaging hard to reach individuals.
Oh, yeah. You know, we've seen a lot of that, Abner, and so maybe we can just spend a few minutes talking about how we kind of address that before we go into the next one. And I will say, from our experience, what we find to be the most important factor to engaging hard to reach individuals is taking a multimodal approach. And what do I mean by that? It means that really meeting the member where they are. We call it our right touch model, but it's really meeting the member where they are so that we can make sure to engage them how they want to be engaged, their preferred communication, being able to really try different modalities to see what works. And so we know for some individuals, for example, they might feel more comfortable with a face-to-face visit. And so someone showing up at their house to be able to assess their needs, talk about different resources that are available, and work with them. Some people might prefer text message or email. And really what we found to be most effective, both for connecting with that member, but keeping that member engaged and really driving outcomes, really getting to that closing the loop solution and being able to document it, is leveraging multimodal. And so whether, for example, you do have a face-to-face visit or you have a phone call where you're talking to the member, you can talk to the member about following up with a text message or an email and get different modalities, because what we find, and our experience has really shown, that that helps significantly increase the outcomes and truly help the members.
Really, really great. The multimodal approach to trying to address what is clearly a major challenge for health plans. It's interesting that the next challenge in terms of the highest percentage is something we've been talking about, which is limited no access to local resources. So I've talked about how community-based groups really struggle, and they're local, but they struggle to connect with a health plan. And when I say connect, I mean contract with a health plan. And it sounds like the health plans are experiencing something similar. They're struggling to figure out, in effect, health plans, it's kind of interesting. Health plans have, for a long time, struggled to build their clinical networks, right? And it's not like that's fixed. It's a constant challenge for health plans to have an up-to-date clinical network and to be able to offer their members, a clinical network that works for the members. That's a struggle. And now we're saying to health plans, we're going to put sort of another set of another, I guess it might be called a burden of the health plan, but now you've got to build a network of community-based groups for your members. And I can see how a health plan would say, look, we're struggling to have our clinical network, and you want to have a social network. I think that's what we're trying to say to health plans. You don't have to struggle to build that network. We can do that for you. And we can, and this is the important part, not only build that network, but have contracts with those folks so they don't have to contract with you directly. Because to ask you to do what they do, to clinicalize social care doesn't work. But to ask community-based groups to almost become healthcare organizations, if they have to learn how to be high trust and HIPAA compliant and do claims, they're quasi. We're asking them to become healthcare organizations. It's not what they do, and we should encourage people to lean into their expertise and what they're passionate about. So I don't know if you want to add to that from your experience and what you're hearing, Meredith.
Yeah, I mean, it absolutely makes sense. That challenge does make sense to me because it can be really hard to build also. It takes time and resources to build an expansive enough network to where maybe you have only a particular population that you're looking to serve. And so to have a network that can serve those needs, that can really understand the local community, that can be time consuming and it can't necessarily be possible for health plans. And so that's something else that comes to mind when I work with the network on a daily basis, right, is that it takes time and effort to really make sure that you're building and managing that network so that they're able to do this work. And that can be hard for health plans. And so that's also something that comes to mind, is really that extensibility and really being able to meet the needs within the different communities, because that's what we do on a daily basis.
And maybe we should talk a little about another area that folks are struggling with. Plans is confirming and documenting the social need closure. And part of this is that plans are under regulatory pressure and pressure from certification groups like NCQA to address social needs, but they have to demonstrate that they're doing it So I can see how plans are saying, look, we want to do this, and when we do it, we want to get credit for having done it, but it's really hard. So do you want to talk a little bit about what we mean by confirming or documenting that the social need was actually closed?
Yeah, I mean, I think that this is one of absolutely a challenge. And for what I've seen for a lot of solutions that are out there, to be completely fair, it can be a gap in the market because I will tell you, it is hard to actually confirm and document that social need closure. And so we've had to put a lot of different kind of instruments in place to be able to get that confirmation. Because, for example, if you go to a digital only solution where, let's say it's kind of a database, it's a network of, it's a curated network where the member has to self-serve, and we'll go into that a little bit more later, but you don't necessarily get that confirmation, right? That the member actually was able to access that service. But what we've worked to do is we've worked to build a platform so that the end service providers, the network as a whole, as well as the members can help confirm, right? They can say, hey, I did get that resource. Was it useful? Did they have enough? Because that helps us also work on true needs closure. Because at the end of the day, we realize that, members, their needs kind of shift over time and what they need. And so just by providing a resource, that's not enough. We have to have a way to be able to follow up with the member and know, did you get what you mean? Or be able to have it documented in another way. And Abner, as you say, in that secure platform as well, so that we can take that data and then we can pass it back to the health plans so that they meet those regulatory requirements.
That's great. And I want to talk just about one more of these. And it's kind of interesting that I think it's that sort of tied, and this is identifying members of social need as not a challenge. And so I want to challenge our listeners, the folks on the web listening to the session, to think about their members and their social needs. So this is kind of a challenge. I'm asking folks to think of your entire membership population, and then think of the folks within that who have a social need. And I'd like for you, I'm going to ask you to sort of, in your minds, think about the difference between sort of two categories or buckets of people who have a social need in your membership. I'm going to argue, as sort of challenging this, that within your membership, the people who have a social need, they fall into two categories. One category is what I would call the folks who can self-serve and self-advocate. These are people who they've run into a problem in their lives. They've got a social need. It may be food or it may be transportation, but where they are in their lives, they're still able to, in effect, self-serve, meaning that if they need food, if you sent them a link to a local food pantry, they would say, okay, thank you, and I'm going to go to the food pantry. I got the link. I know where it is. I see that it's in my community. I'm going to go there. But if they go there, and this is an example, and that food pantry is only open on Wednesdays, but it's Thursday. They need food on Thursday. The food pantry is only open on Wednesday. That member I'm talking about that can self-serve or self-advocate, they will say to themselves, okay, if there's one food bank, maybe there's another, I'm going to go back home and look for another food bank that's open on Thursdays. Or they might say, I'm going to figure something out and come back next Wednesday. But they're in a situation in their lives where they can't, I call that self-serving and self-advocating. They with a little bit of help, they can figure out how to get their need met. That's one group of your members. I'm going to argue that you've got a group of your members who fall into another bucket. They are folks who they're your members still, but they have complex needs. They are really struggling. Sending them a link is not going to do the trick. It's not going to work for them because they have perhaps multiple needs. They have food, transportation. They might have housing insecurity. They might have just gotten out of the hospital after surgery. And we've had many of these instances where they can't physically get to where food is. They might be at a point in their lives where they just, it happens to us humans. We're just knocked on off our feet, and they have lost self-confidence. They've lost self-esteem. Life has just thrown them a curveball, and they don't know where to turn. They don't know who to trust. They're even reluctant to answer the phone. And for those folks, I call them sort of high need, complex social need members. Sending them a link is not going to work. And so I'd love for us to talk a bit more about that bucket of people who have they have complex needs. We've talked to health plans, and some health plans tell us that people who fall in that category can be 20, 30% of their member population. So we're not talking about a small number of people, but they are costly, and they are the highest need. And they're the folks that I think we ought to not forget. Even when we are able to solve the need of the folks who can self-serve, we need to remember that there's a whole group of people that need a higher touch. They need a human touch frequently. Sometimes a technology solution is just not going to work for those folks. And you need a combination of services and technology. And that's why community-based groups who are local, who can actually interact, go meet that person. So I'm going to ask you, Meredith, if you would, to talk a bit about these high need members, and maybe give us an example of how GroundGame.Health is addressing these folks with complex high needs.
Yeah, definitely. And I think this ties well into even the challenge too around measuring impact that a lot of people also said was an issue, because being able to watch the member go through the life cycle, I think we're better able to measure impact. And so let's go into a case study. And so I'm going to share my screen again. And so this is a prenatal program in Georgia. And so these are members that we're working with, that they're higher need individuals. They're Medicaid members. They've all been identified as being pregnant by their health plan, but they've not gone to a prenatal visit. So Abner, they fall specifically into that category that you're talking about. We were asked by the health plan to both be able to help them navigate to a prenatal visit, as well as help remove the barriers to the social needs. And so just for a little background about maternal mortality in Georgia, Georgia has one of the highest maternal mortality rates in the country. And so it's almost 34 deaths per 100,000 live births. And in 2022, 7.6% of live births in Georgia were to women who received late or no prenatal care, and that's higher than the national average. And 15.6% were to women who received inadequate care, also higher than the national average. And so what we found is that specifically within Georgia and within these mothers, what was contributing to this was very complex health-related social needs. And so we were given the subset of members by a health plan to be able to assess the member, help them close these social needs, drive them into that prenatal visit, and also be able to close the loop. And I will tell you, we're going to go into some of these results and kind of measure the impact. What we found is that this is very true. And so you can see some of the stats from this population. And so of the population that we were given, 77% of the members that we reached, they completed a health assessment. And so that could be something like prepare. It can be additional questions as well as we get to know the member, learn more about their needs. As the care coordinator hears something and is, I want to dive into this more. And what we found is that this population within Georgia, the average number of social needs was 7.4 social needs identified per member. And if we're looking at it compared to our average of other members that we're looking at, that's closer to 3.4. And so you can see almost 4 more needs identified per member. So those stats and kind of the research that was done in October of 2023, we have found it to be very true in our interactions. And now what we've also seen is that 80% of the needs that identified of the members that we've been working with, they've been met. And so some might ask, okay, what types of needs did they have, right? And so there were the healthcare needs, absolutely. There was a lot of food insecurity. There was financial stability issues, as well as transportation needs. And so those were some of the top needs, just to kind of give context to it. And so what we really found is that out of all those members and that average number of social needs, 89% of those members that we were able to assess, they had social needs. 94% had clinical needs. So a few that we had gotten in touch with, maybe they had gone for that prenatal visit by the time we were able to connect with them. But 83% had both the clinical and the social needs. And so what we really see is this is a high need population, but they're very open and receptive. These are the members that need that human intervention. They don't just need to be sent somewhere for self-service. They really need someone to help guide them, to advocate for them, and they are receptive to it because 80% of those needs that we have identified have been met.
That's incredible. Amazing success with a extremely challenged and vulnerable population. So question, and I want to double click on this. So why is it so important that health plans collaborate with local community care folks, with local people who are geographically closer, who have trust, who understand the unique needs and circumstances that a mom in Georgia, rural Georgia, for instance, might have? Why is it so important that we involve those local community-based groups and local care coordinators in solving these problems?
Yeah, absolutely. So let me give you what I think are kind of a few key highlights from that question. And then I'd also like to go into some specific member stories to kind of highlight why it is important and the type of impact. And so I think it's really important. And what we have experienced is because they really know, they have that local understanding. They understand how to advocate in a way that makes sense to the members. And so that local knowledge, it really helps them be able to drive, okay, which end service providers? Are there different faith-based organizations? Are there food pantries? What's available to help solve those problems? They also might have trust already established within the community. And so we work with specialized cohorts or specialized individuals with these types of complex needs where maybe there's a particular organization in the community that already has a name for itself because it's very reputable with, for example, something like this prenatal population. And so there's less stigma, or there's more trust that's already involved with really working with those members as soon as they know that it's that local organization. And so let me just share a couple of these stories where it involved local organizations and some of that local advocacy. These are real examples. The names have been changed to protect privacy, but they really are real examples. And so the first is Maria. She was a 28-year-old Medicaid member, and she was contacted by a care coordinator because she was pregnant. She had been referred to us because she had, again, the same parameters, no prenatal visits, and was suspected to also have health-related social needs. And so what we found out is that due to the stress of Maria's situation, she wasn't gaining weight. And she also just didn't feel like she could go in for an appointment, for a prenatal appointment. What we found is that she needed temporary housing, she needed permanent housing, and she also felt a great stress because she wasn't prepared for the baby to arrive. And so there can be a lot of kind of fear and stigma around admitting these types of things as you're pregnant because you don't feel like you can take care of the needs. And so having that care coordinator, having that local resource to be able to build trust with the member, to open up, to disclose this information ultimately drives the care coordinator to be able to help Maria meet her needs. And so she was able to gather this detailed information. And what she found out is because Maria didn't have permanent housing, she found temporary housing agencies in the area. And so she found some different federal ones as well as local ones. And she was able to give Maria the different options based on her preferences. And help meet that immediate need. But we know that that only meets the immediate need, right? And that was Maria's stated, that was her top priority, was that housing. So we were able to meet that immediate need, get her set up with the temporary housing after she had been living in her car, right? So she was living in her car. And then once she was in a stable environment, she had that temporary housing. We were able to look at solutions, long-term housing solutions. And Maria was also able to start to think about things around, okay, I'm getting my social needs met. I know that I can go in and start to get that prenatal care. And so the care coordinator was able to not only assist Maria with that short-term housing, but then the long-term housing and getting support to help finance for that permanent housing. She also received some of those much needed baby supplies that she had been concerned about, such as the car seat. And she got that through her health plan because our care coordinator can work with the health plan to be able to access the resources that are available to her, but then also worked with local charities to get additional baby supplies so that she knew that when she was ready to deliver, she could take care of her baby. And so, before her baby was born, she was able to pick up the keys to her new apartment. She gained weight. She got into a better spot. She was able to close a lot of those social needs because the care coordinator could help her navigate through these situations, right? Locally, what was available to her. She built that trust to get her to open up so they could really see what her situation was and her barriers. And ultimately, they closed those social and clinical needs. And then we have another example that I want to share because to me, this is interesting because something that we really try to do is we really try to listen to the member. Something that's really important for us is we may think, for example, like in the case of Maria, that housing would be your absolute top priority. If you're living out of your car, temporary housing would seem like maybe the top priority, but everybody has different needs and different perception of what their most priority needs are. And we're here to listen, we're here to guide, and to really get the members connected to in a way that makes sense to them based on their perceived needs. And I think that Deborah is a good example of that. So Deborah was also pregnant. She was in her third trimester. She wasn't employed, and she had nothing prepared for the arrival of her baby. Again, she didn't have any prenatal care as well. So she hadn't been attending any regular or ongoing medical appointments, excuse me, and they needed to find her a doctor. She also needed help with rental assistance, baby supplies, and exploring childcare options. So the care coordinator again was able to uncover these different needs, and based on Deborah's perceived need of finding rental assistance first. So even though she was in her first or her third trimester, it was really looking for that rental assistance. And once we could meet that need, and the care coordinator was able to look into local programs to help with that rental assistance until she could go back to work, and start looking at baby supplies, then she was able to start thinking about those clinical needs. And so obviously the care coordinator knows that there's a time aspect here because we need to get her into care as quickly as possible, but we also need to build the trust so that we can ultimately continue to engage this hard to engage member, right? And so by being able to text, by being able to meet the needs, having this, local knowledge to be able to quickly navigate temporary housing solutions, get baby supplies, and then work on some of those more long-term needs as well, we're really able to solve over a paradigm according to the members' priorities and really use that local knowledge to help the members navigate.
Great. I think we've got a question that came up. For the Georgia case study, how successful were you in supporting members to get their prenatal visit done in the first trimester for the HEDIS prenatal care measure? So this is someone who's concerned about those HEDIS measures and getting it done in the right time frame.
Yeah, Yep. So we absolutely are aware of the HEDIS measures. And so what we do is we are able to, based on, and I'm going to stop sharing my screen right now just to be able to answer some of these questions. So we are able to prioritize members where they are in the journey. Ultimately, we still want to listen, because if a member doesn't feel listened to, then that can impact our ability to remove those social barriers or those barriers that are preventing them from getting to care. And so I don't have the stats here, but that's something that's great in terms of follow-up. We are able to, as long as we get the identification of the pregnant member, then we immediately get to work on outreaching to the members, seeing how can we get in touch with them so that we can drive them towards that HEDIS gap closure.
The all-important HEDIS gap closure.
Yep.
I want to encourage the folks in the session to please put your questions in the Q&A, just like that person did. We're happy to answer them. One thing I know that comes up with us frequently, Meredith, and I just want to touch on it, is this idea of transformational versus non-transformational needs and the difference between the two, and why we don't want to just focus on the one and not the other. Do you want to chat about that just a minute?
Yeah, so I think first of all, we should talk about what transformational versus non-transformational is.
Right.
And then let's talk about it. Yeah. So we use those terms because and it's not to say that one is more important than the other, right? But to us, a non-transformational need is just meeting an immediate need, right? Like if you don't have food today, we need to figure out how to get food on the table today. But that doesn't meet the long-term or the transformational need of ultimately getting food security. And so we do feel the need to delineate between those needs, because at the end of the day, we need to meet those immediate, quote unquote, non-transformational needs, but we ultimately want to drive true needs closure with meeting transformational needs. And so we'll obviously see, and a lot of times what we'll see is we'll see where a member will have that, or maybe they'll state that immediate need, like, hey, I'm really hungry. Is there food pantry around? And so we'll use that as an opportunity to be able to think about, okay, that's the short-term need, but let's dive into this a little bit more. Is there something that maybe they are starting a new job in a week, and so they're going to have a paycheck coming in, but there's this gap, and so really it's only a non-transformational need that we need to meet? Or is it something more long-term where we need to help them navigate like a WIC application or a SNAP application or meet other needs, right? I specifically remember a member story where our care coordinator was helping them navigate to get one of those transformational needs met with a SNAP food application. And their application was denied because they had an outstanding utility bill that they didn't even know that they had. And what they ended up finding is that someone was coming to their house in the middle of the night and taking water from them. And so we met the immediate need that they had, the non-transformational need of food. We also knew that we had to help that transformational need of that SNAP application, but we uncovered another need in the process, which was helping with the utility bill, because that was there and their SNAP application was going to be denied because of it. And so it's really being able to solve, understand, and get to the root cause of, okay, where does this need come from? And are there different layers of it? Because we know that just directing someone, a member, to a food pantry isn't necessarily going to meet that long-term transformational need.
That's really great. I love the distinction, saying both are important. You got to feed folks tonight, but we need a longer term solution so that they have food on an ongoing basis, and that we need to do both. So I love that distinction. So you shared, now I think that's actually 3 stories. 2 we went through the slides, and now a third. But that's 3 stories. So can you talk about how GGH has been able to scale this solution? So, you shared 3 stories, but what are we doing across the country so that people have a sense that this could be a solution that they could partner with?
Yeah, absolutely. And I will tell you, like, that's what we've spent years doing. We've spent years building the network to really be able to connect, as you were saying, Abner, but connect health plans all over the country to local networks and be able to have the documentation, being able to have the instrumentation, being able to support effective outcomes, to be able to measure the impact. And so we've spent years figuring that out. And the way that we connect CBOs and resources to individuals who need it most, we really look for ways to optimize this work and make sure that individuals get what they need. We need to leverage resources in a way that's strategic and so that we can do it at scale. And just to put it in perspective for you, in 2024, so far, I will say that we've ingested over 600,000 members. Okay, so we've outreached to over 600,000 members for high needs. We've infused more than $17 million back into the community, and we've been able to solve more than 150,000 social needs and counting, right? Because there are a lot that are in progress too, because we know that maybe a transformational need takes a little bit longer than a non-transformational need. And so I've been sharing these individual stories, but I think that those numbers help show that it can be done at scale. It takes the right amount of work. It takes really the understanding of how to be able to drive this, but it's currently being done at scale. We are doing it at scale. We are working all over the United States to be able to connect community partners to health plans and to be able to close these social needs. And so, Abner, I want to flip a question to you now, take it one higher, because I know I've been talking a lot about the individual members' stories, the particular, case study within Georgia and those individuals. But I think I would be remiss if I didn't talk and ask you a question, because you've been working and been involved in health equity for so long. And there's been a lot of conversation about the need to solve these social needs and how to address these health equity issues. What do you think you're most concerned about as it relates to being able to scale this across the country?
That's a great question. So I think one thing that really concerns me, and I mentioned it, but it's so important, I want to mention it again, is that as health plans put together their strategy to meet their members' social needs, it's really, really important. I can't stress this enough for the health plans to distinguish between those members who can self-serve and self-advocate and members who have a much more complex situation, set of needs, are in a position in their life where they can't self-advocate, they can't self-serve. As I said many times, they are just like they've been thrown a curveball by life, and they don't know where to turn. They don't know who to trust. They don't. They're kind of frozen, and what they need is a much more human touch combined with technology, but certainly a more human touch. They shouldn't be forgotten about. And it's really, really important that our health plan partners, as they're developing their strategy, they don't just focus on those members who have less complex needs that can, using my example, you can send them a link and feel like you've solved the problem. That doesn't describe all members. So I really want to challenge the folks from health plans who are here in the session. Take a look at your membership and really figure out which category a given member with needs fits in. And then my question is, do you have a solution for those high need folks? Because we think the best solution is to partner with community-based groups. In fact, our challenge is I think you'll struggle to solve those problems if you try to do it on your own. So one thing that concerns me is plans sort of checking the box because they have a solution that addresses the sort of the easier to resolve folks and doesn't address those high need members. Because from a ethical and moral standpoint, but also from a financial standpoint for plans, it's really important to make sure that we have a solution that meets the needs of those complex higher need members. So that's one thing that really concerns me. A second is And it's kind of tied to that. I do think it's really important that we, and when I say we, I mean our health plan partners, that as we move along this journey, and it's a good thing, our country is changing in a good way in this instance, where we're trying to break down the silos between clinical and social. Health plans and other stakeholders are being asked to see that member as a whole person, not as part clinical and part social, but as a whole person. And they're being incentivized and in some cases required to address those social needs. So it's really important that as a health plan is on that journey, that we hold on to this idea that what really matters here is results. We cannot confuse efforts with results when it comes to meeting health-related social needs. Efforts are necessary, but they're not sufficient. And it's really important that we stay laser focused on the goal here. And the goal is to help people get to a more stable place in their lives. And as an example, if someone, using one of the examples from the Georgia study of moms, pregnant women, if they've got 7 needs and we solve 1, our work is not done. And we shouldn't check the box and say we're done. We need to see that woman in a holistic way, and recognize that she's got 7 needs. And as daunting as that sounds, I also want to be encouraging that we know for sure, because we're doing it, that we can solve those needs by partnering with local community-based groups. We can do it in a sustainable way, in a cost-effective way that doesn't require the health plan to become a social service organization or the social service organization to become, a healthcare organization. We can allow people to lean into what they do best and what they're passionate about. And by doing that, we can help people solve a myriad of social problems. So I don't want people listening to think, oh my God, this is impossible. It's just the opposite, that this is a moment of opportunity for us, like I don't think we've ever seen before in the country. And I'm really encouraging health plans and other stakeholders to lean in and to partner, because that's the way we're going to solve these social needs. So with that, I think we've got some, do you have any more comments, Meredith? Because I think we want to leave some time for some questions.
Yep.
We've got some
Yeah, let's get into a few questions. I think
I don't know if Eric is going to lead us, so we can just do it ourselves, but let's look at the questions. And people and folks in the session, feel free to add questions even now if you have them.
Yeah.
Yes, as Abner said, you can submit questions via that Q&A button at the bottom, so please go ahead and do so. And thank you to everybody who has already submitted questions. So one of the questions you guys have received is, have you worked with members who have distrust of the healthcare system and or prefer their own traditional/cultural health practices? And how do you overcome those barriers?
That's a wonderful question, and it's a really insightful question. The answer is yes, absolutely. I mean, I would probably be lying if I didn't say that that sorry, that
You're
we
a
don't.
trooper.
Yeah,
You're
seriously.
a trooper,
No worries at all. No worries at all.
That we don't face that on a daily basis. And so we actually there are trainings that we go through to help really be able to both appreciate different cultural backgrounds, be able to speak to members in different ways, depending on kind of their own cultural beliefs and their cultural backgrounds, as well as how do you work to be sensitive to those types of barriers as well as overcome them. And so there's a lot of work that goes with the team, goes into training the team, that goes into training the network to be able to kind of address some of those issues, because there are large pockets of the population that have a mistrust of the healthcare system, or they've had a bad experience. And so they might say, like, why are you asking me these questions? Why do you even care about me? Or maybe it's something where they prefer traditional medicine. And so it's really being able to meet the member where they are and help train and equip your team to be able to understand and appreciate those different cultural backgrounds, to be able to know how to actually respond when they face those types of interactions.
Great.
Great. Yes, thank you very much. That's super insightful answer there. So another question we received is, how do you coordinate with the internal care management teams working with the different insurance providers?
Yeah, Abner, I'll take it then if you want to add anything. And so we have ways in which we can set it up so that we know and we have visibility into when it's a different insurance provider, that we're able to see the health plan. We're able to see, for example, we go through an implementation to understand what the workflow is, what's the referral process, for example, if we are referring to a care management team, or we even have care management teams that refer directly to us as well. And so during the implementation process, we set that up, and everyone has visibility both into the workflow and the system set up in a way to be able to appreciate that workflow, depending on the group of members that you're working with, as well as our team is equipped to be able to know exactly what insurance provider the member's coming from, different things like that. And so our system's built to be able to provide that visibility and to be able to appreciate those nuances and workflows and ways in which you have to interact with the member based on kind of those different variables.
Yeah, that's great. The only thing I'll add is that, we work with, I think, 7 of the largest health plans in the country, as well as many others. So our technology platform and our experience working with health plans is really extensive. It's kind of, we're kind of, as I said, bifurcated. On the one hand, we really partner well with the health plans. We know them. We've been working with them for many, many, many years. We understand their needs, their unique needs, sometimes a little crazy. Health plan, every health plan is different. And so the nuances, we understand that, and we can partner in a way that takes that into account. But at the same time, sort of looking the other way, we can partner with the smallest or the largest community-based group and contract with them and not ask them to do anything really different than what they are passionate about, what they exist to do. And that's the magic of what we're doing. We're able to translate between these two sides, the two types of organizations that just struggle to directly communicate. We provide I call it pipes. We provide the pipes that connect these two, so that from their perspective, it's pretty seamless. They're just doing what they do, except that by connecting the pipes, just doing what they do allows us to solve social needs in a way that is just almost miraculous. It's a pretty amazing thing to see. And we've got some amazing stories. You've heard some of them, but we've got many more. So we'd love to share those. So I'll stop there because I think we've got other questions.
Yeah, absolutely. So another question that came in is, how do you address missing or invalid member contact information?
Yeah, that's a great question. So as long as we're set up to do so, we do have a technology that can look for additional, for example, phone numbers, alternate phone numbers, email addresses, and different contact information, physical addresses, to be able to locate the member. And so when there is that missing information or that invalid information, we can also tell up front, for example, we run it through our platform, and we can know if a number bounces before we even ingest that member into the system. And so depending on kind of how we're configured, depending on what we are able to do, we're able to use that and leverage that ability to be able to fill in missing dots. And within our interactions too, so let's say that we do get in touch with the member, for example, we're always looking for alternate contact methods. And I think that that's an important piece, particularly for the Medicaid population, because we know that phone numbers can change pretty rapidly. Addresses can change, on a more regular basis. And so keeping the most current contact information as possible for all members, but particularly the Medicaid members, and really making sure that they think about, and we're planting seeds throughout that, hey, if you change your phone number, don't forget to update it with the health plan, or don't forget to let us know. Or if they're going to run out and they're not going to be able to know or pay their phone bill, let's figure that out, because we don't want to lose contact because of those challenges that many Medicaid members do face.
Great. So I think we have less than a minute left. We're almost at time here. So I just want to give both of you the chance, if you have any closing thoughts or anything else you want to say before we end today's session.
Anything, Meredith?
Yeah, I just want to thank you all for coming today. I know that this work is really hard work, but it's work that's so important. And I really do believe that by meeting members where they are, being able to close their social needs and help them address those social needs, that we're ultimately also going to be driving better health outcomes. And so I thank you for your time today, and thank you for showing up for the webinar.
And I'll just say thanks for showing up, and please reach out. We are looking to partner. We've got an amazing solution, and we'd love to talk to you more about it.
Great. Well, I will also thank everybody for showing up. And I will thank both Abner and Meredith for sharing the great stories and how GroundGame.Health, like you said, really helps drive better health outcomes within the Medicaid space. Thank you for everything you guys do. As Abner said, feel free to reach out, right? You can reach out to GroundGame.Health directly. You can also reach out to me at MHPA. I'd be happy to make any connections as well. I can vouch. Everybody on GroundGame.Health is lovely. I'm sure they'd be more than happy to talk to you. And just another reminder, this webinar was recorded. So if you ever do want to revisit any of the great content Abner and Meredith shared, you can feel free to find that recording on MHPA's YouTube channel. With that, thank you again to everybody involved, and we'll go ahead and close out the session. Have a great afternoon, everybody.
Thank you.
Thanks.